Okay, good morning, everyone, and welcome to this morning's webinar series. Today we have two talks from Groote here, focusing on andrology this morning. We first have Dr. Rhode, who will be chatting to us about erectile dysfunction, particularly looking at the evaluation and investigations thereof and management. And then we have Dr. Hugo, who will be focusing on the pathophysiology and management of premature ejaculation. Dr. Rhode, you can come forward and we can start on the first talk. Thank you.
All right, morning everyone. Today I'm going to be going through the evaluation and management of erectile dysfunction. And we know that erectile dysfunction is a condition that, as we'll see, extends beyond the bedroom. It's a barometer of cardiovascular health. It's a window into the metabolic disease burden of the patient. And increasingly, it's a condition that's presenting in younger men than we might expect. In preparing for this talk, I took a lot of the information from Campbell's, the 13th edition, as well as the EAU guidelines, and then the International Consultation on Sexual Medicine consensus. A lot of these overlap and quote each other. Great. So let's ground ourselves in the epidemiology. 322 million. They say that's the projected number of men that's affected globally in 2025 by erectile dysfunction. The prevalence in adult males sits at about 20% of the male population, and we know that it rises steeply with age. It starts at single digits when they're under 40 years of age, and beyond 70, about half of men are affected. But the one stat that caught my attention when I was preparing this is that 1 in 4 men presenting with erectile dysfunction is under the age of 40. And of that 1 in 4, 50% have severe erectile dysfunction. So this isn't just a disease of the elderly. We need to be asking about it across the age spectrum. Now, the real clinical pull on the slide probably is this comment, and that is that erectile dysfunction is a cardiovascular sentinel marker or a harbinger of a cardiovascular event. To drive that home, we know that sort of the biggest data relating to that statement comes from a subgroup of the prostate cancer prevention trial that looked at men presenting with erectile dysfunction and their risk of cardiac events. And we know that there's a 45% higher risk of a cardiac event in 5 years in men who present with erectile dysfunction. And by 10 years, 80% higher risk of coronary artery disease. This is comparable to cigarette smoking. So it's an independent risk factor. It's funny, because we'll often write smoking when we write our notes and then go on to say cardiovascular disease and that. But one should actually be saying, erectile dysfunction present or not. So when a man walks into your rooms with ED, you're potentially seeing not only erectile dysfunction, but the first presentation of occult cardiovascular disease. And that changes how we evaluate patients. So to understand the treatment, we need to understand the physiology of erection, which is, you probably can't move past this topic before someone asks this question. And we remind ourselves that erection is a neurovascular event. It starts centrally with a sexual stimulus. It's mediated by the parasympathetic nervous system, specifically the non-adrenergic, non-cholinergic nerves or cavernosal nerves. And I want to first just bring your attention to this side of the diagram, which is the most commonly quoted side. We know that the neurons are going to release neuronal nitric oxide synthase. You're going to then synthesize nitric oxide. It's going to give rise to guanylyl cyclase. That's going to convert GTP to cyclic GMP, and that's going to drop the calcium in the cell. It's also important to understand for other agents that you've got a secondary pathway, and that secondary pathway is driven by prostaglandin E1. That's going to cause the release of adenyl cyclase. That's going to convert ATP to cyclic AMP, and that's also going to drop the intracellular calcium. So what that does very simply is we remind ourselves that for muscles to work, you've got a cross bridge, and that cross bridge is dependent on calcium. You don't have calcium, the myosin head dissociates from actin. You've got smooth muscle relaxation. Cavernosal bodies fill with blood. Pressure increases. You compress the subtunical vessels, and that's your venous trapping mechanism or veno-occlusive mechanism. How do you then switch it off? Well, we know and we can see that you can degrade both cyclic GMP and cyclic AMP through the action of phosphodiesterase 5, as well as 2, 3, and 4. And I think the significance of this comes in later when we talk about our synthetic prostaglandin E1s, as well as our phosphodiesterase inhibitors, and then your non-specific phosphodiesterase inhibitors. But it's crucial to communicate to patients that for an erection, as mentioned, you need some sort of sexual stimulation. And that's an important concept for spontaneous erections, but it's also an important concept when we talk about our medication. Now, at the bottom of this diagram, you're going to see an etiological classification. And the most common etiology behind erectile dysfunction is probably vasculogenic. But a large majority of these patients have mixed. They've either got a combination of that. The important thing is probably not to pin it down and say, this is vasculogenic, but to identify what is the overarching risk factor and try and deal with that. It's worth highlighting our drug-induced causes on the far right-hand side of the screen. And up to 25% of patients, it's due to drug-induced. We've got tons of patients that are on thiazide diuretics or Rhode, and that's probably one of the big ones. There's also beta blockers and selective serotonin reuptake inhibitors. These are the major modifiable risk factors with their adjusted odds ratios. And the one that jumps off the screen is obviously antidepressant use. It's got a 9.1 odds ratio, followed closely by, or not so closely, but the next biggest one is antihypertensives, then diabetes. And then you've got this combination of hypertension, obesity, smoking, and physical inactivity. And they all cluster in and around 1.5 to 1.6. Individually, they seem inconsequential, but I mean, we need to remember that patients often have coexistence of all of these. They've got a hypertensive patient who's diabetic, who's on antihypertensives, and they could also be on an antidepressant. Now, at the bottom of the screen, I've also included some data from the COVID era, and that was sort of interesting. I think it just speaks more to the physiology that we're well aware of. And essentially, there was an increase in the amount of erectile dysfunction. The theories behind that is that you had endothelial dysfunction. We know that it's an inflammatory disease. Lots of people got pulmonary emboli, but that seemed to also disrupt the vasculature to the penis. Now, this is a classic sort of concept, and it still remains clinically useful with the caveat that most people probably are a combination of psychogenic and organic erectile dysfunction. When it comes to this, the history really does the heavy lifting, and we know that psychogenic ED tends to be sudden in onset. It tends to be situational. The patient can achieve erections outside of intercourse, perhaps with masturbation or with a different partner. Morning erections are preserved. And this is in contrast to organic ED, that is the opposite. Organic ED tends to be gradual, tends to have global dysfunction, and you've got the absence or diminished morning erections. I want to emphasize this point at the bottom, which that most presentations are mixed. And it's important to be aware of that because you can have a man with organic vasculogenic ED who now develops performance anxiety, which compounds the problem. Converse is also true. You can have a person with a primary psychogenic ED who's now struggling for months, and under the stress that's associated with intercourse, they can then have endothelial dysfunction. So what matters is not so much, psychogenic versus organic purely, but it's trying to see which is this most likely and how can that influence how you're going to treat this. Right, so this is a basic evaluation structure, and a patient doesn't need more than a focused consultation when it comes to evaluating erectile dysfunction. And that focused consultation to start with, as we've laid out, we're trying to separate what is the cause and is it psychogenic or organic. And therefore, you're going to ask, when did it start? What's the duration? What's the severity like? Is it situational or global? What's the morning erections like? Does the patient still have a sex drive? How's the ejaculatory function? And have they tried any treatments? For how long? At what dose? And what was the response? And then it's important that you score them on some sort of objective parameter or scale so that you can compare that. Probably the most quoted one is this International Index of Erectile Function 5. I remember reading this many times and just pulling it out on the calculator and calculating it. But essentially what it's doing is running you through the sequence of how a man has intercourse. It's that, what is the confidence that you can get that erection? What is the confidence that the erection is able to stay there to penetrate? After penetration, can it be maintained? Can it maintain long enough to climax? And then finally, if you had to, almost like a survey at the end, how happy are you with the intercourse? What would you score it as? If you score those factors, we know that high numbers, then classify it as is good. No ED is 20 to 25. And then it's subcategorized as laid out on the slide as severe, moderate, and mild. Moving to the medical history, that centers around the usual suspects. You want to know about cardiovascular risk factors, diabetes, neurological disease, have they had pelvic radiation or surgery before, and you want to go through their medication. As mentioned, thiazide diuretics, SSRIs, you want to see what they're on. It's important then also to not forget to ask about recreational substances such as alcohol and cannabis. The one we probably fall short on is the psychosocial component. In doing my reading for this, I thought there was a little pearl that I saw, which is that probably the most useful is 2 screening questions. And if you've ever done the Discovery Vitality annual screening question, this is exactly what they use is, are you feeling down or hopeless? And do you still get enjoyment from the things you usually used to get, which is broadly termed as anhedonia. Using those 2 questions, you can quickly sift out, is this someone that's got a predominant psychological issue driving this? And that can help you to get that patient closer. What is it? Yeah, muted. Okay. Oh, sorry about that. Right, 2 screening questions. Okay, all right. And then we move on to physical examination. So that's going to include anthropometric parameters, the height, the weight, the BMI, the blood pressure. You're going to examine the genitalia. You're looking specifically for plaque associated with peyronie's, testicular size, feel the peripheral pulses, look if they've got an overt neurological cause. And then bloods, very simple. We've got a nice form here at Groote, and it summarizes what is the recommended minimum bloods for an erectile dysfunction workup, which is to have a glucose fasting or HbA1c, a lipid profile, as well as a testosterone that's taken at an appropriate time, which is between 7 and 11 in the morning. If that testosterone should come back abnormal, they recommend that you take a second one, because about a third of patients, when you repeat that testosterone, they're going to have a normal testosterone. Should the testosterone still be low, then one needs to add a free testosterone, a luteinizing hormone, and prolactin. Right. So specialized investigations, I think it's very important just to clarify before diving into all of this, because it can become a very academic exercise, but across all the guidelines, these are not routine investigations. These are investigations that really serve a niche purpose. They're specialized testing and they're reserved for specific situations. So the first one I want to look at is penile duplex Doppler ultrasound, and it's the most reliable and least invasive way of assessing the vasculature of the penis. Thresholds worth knowing is that your peak systolic velocity above 35 tells you that you've got normal arterial inflow. If it's below 25, you've got arterial insufficiency. Between 25 and 35 is a gray area, so they recommend you correlate it clinically. And then your end diastolic velocity, that tells you about what's your venous leak like. If it's above 5, then it suggests that you're leaking. You've got a venous leak mechanism there. If it's under, then it's probably fine. And then your resistive index. That tells you how well can you occlude your veno-occlusive function. So it should be more than 0.9. That confirms that you've got a normal veno-occlusive mechanism. The other ones that's often mentioned in the text is your nocturnal penile tumescence and rigidity, or so-called RIGI-scan, which it has a niche role. It's basically to separate a person that you're uncertain is a psychogenic or organic, and it's got a device as shown here that connects to the penis, and it measures erections in the night to see if you're having sort of spontaneous erections and the quality thereof. It sort of says that this is used for unclear cases or in medical legal settings. It's not a first-line test. And the other one worth mentioning is your dynamic infusion cavernosometry. And that is often combined with penile angiography. And the select population that's useful for is young men who you suspect they've got a traumatic arterial injury, or they've got a site-specific venous leak, and they might be candidates for revascularization. They obviously need penile angiography beforehand. When one considers the hormonal side, as mentioned, if you've got a low testosterone times 2, you're then going to do the LH. If your LH is elevated and your testosterone is low, you're dealing then with primary hypergonadism, and you're going to work through that workup for that. If your LH is normal or low and your testosterone is low, then you've got secondary. And the key one here to consider is combining that with your prolactin test, because you have to consider whether you're going to do MRI scanning of the head for pituitary lesion. Right. So the second component that's sort of important when you're drawing up a risk stratification for this patient is to do a cardiovascular risk stratification. And this really is a non-negotiable. Every patient should have this that has erectile dysfunction before you initiate treatment. And the Princeton consensus guidelines, or the Princeton guideline, gives us a practical framework for this. We're trying to get patients into 3 categories: low risk, intermediate risk, or high risk. And low risk is patients that have got controlled hypertension, mild valvular disease, or they've got less than 3 risk factors for coronary artery disease. So those risk factors for coronary artery disease that they list is that the patient has erectile dysfunction. That's one risk. They've got early erectile dysfunction is another one. So under the age of 60 is deemed early erectile dysfunction. Family history, so a dad that's under 60 or mom that's under 55. And then your conventionals: hypertensive, diabetes, smoking. Those are all risk factors. If you've got less than 3, then you're low risk. And for the low risk patients, you can take a step forward and start initiating treatment, but you should counsel them on lifestyle modification. Your intermediate risk, as you can imagine, is a little bit of a gray area. You've got 3 equal to or more than 3 risk factors: moderate or stable angina, or you've had an infarct that's at least 2 weeks ago, but under 6 weeks. Those patients, you need to get assessed by the cardiologist. And then from there, they need to decide, is this patient going to fall into low risk and you can proceed, or are they high risk and you need to wait? And then your high risk patients is quite self-explanatory: unstable angina, uncontrolled hypertension, severe heart failure, or they've had an infarct or stroke in the last 2 weeks. Those patients need to cool down. They need to be treated first for their cardiac condition and stabilize before you treat any ED. So this is an overview slide, and it's the framework that I've sort of put together from what I saw from the guidelines. And it's a framework to have a structured conversation with a patient. I think the important concept here is the shared decision-making with patient and partner. And that's an important concept, is that one, it needs to be a shared decision. And I know that term is thrown around very loosely, but I think it drives home the fact that often we see patients in the government sector and we just assume that they are not by the means to afford something. And that potentially robs a patient of, a treatment if they don't understand everything that's on the menu. So you really have to lay out every option and tell them, sort of what is appropriate for them. And you'll be surprised. I think in our experience here is we can get Trimix. I've seen someone for Trimix and they can get it at about 300 Rand for a box of for a 5 ml ampule, which isn't too bad. And I think a lot of men that are distraught that it's causing a lot of anxiety will find that money, which means that if you don't tell patients about intracavernosal injection, you're potentially robbing them of that opportunity. All right. So, it's 6 pillars that are laid out, but the idea is that people can also skip over. It's not that you have to follow it. And they even make recommendation that some men can choose to not have PDE5 inhibitors and go to penile prosthesis. I think it's a radical statement. But I think I get the concept that you can choose to jump ahead on the treatment algorithm. So starting first with lifestyle and risk factors, there's some good data. There's an RCT that I read that showed that if you combine weight loss in obese patients with a Mediterranean diet, there's quite a significant improvement in the International Index of Erectile Function that you can get. So that means that it's not only healthy for them, but you can actually sell it that, this can improve your erection on your own. Psychosocial therapy, best done as, we all know about cognitive behavioral therapy, but I think the important thing is you need to have a partner involved. And how many times you see these patients and they're alone without their partner, and then you don't kind of have an understanding. And I think it's also important that partners are always involved, because you're going to choose an option that might influence them or that they can help with, like ICI. Testosterone replacement. So if the testosterone is below 300 nanograms per deciliter on 2 morning samples, then you should start them on replacement therapy. You need to proceed with that therapy for at least 3 months before saying that it's not working. And then they say that you can augment that even with phosphodiesterase inhibitors or others. And then we move to our pharmacotherapy, and that includes our phosphodiesterase 5 inhibitors, our medicated urethral systems, as well as our vacuum erection devices, and penile prosthesis. So I think the one that we all need to know about is phosphodiesterase 5 inhibitors. And I think just, letting the water settle from the mud here is that you've got 4 agents that have all got equal efficacy. Uh, and they say that number is at approximately 70% successful intercourse on them. So the key difference really lies in the pharmacokinetics of the agent. And by understanding that pharmacokinetics, you can put it on the table for the patient and tailor the choice. So sildenafil and vardenafil have very similar profiles. They're rapid onset, 15 to 60 minutes. They've got a half-life of 3 to 5 hours. With both of them, food intake reduces absorption, so you have to advise taking it on an empty stomach. Vardenafil has an added concept that you have to be aware of, and that is that it's the concern around QT prolongation. And so if you're using certain antiarrhythmic agents, you have to consider that. Tadalafil really is the outlier in the group. It's got a 17.5-hour half-life, which means that it's got a much wider therapeutic window. You take a dose on Friday, and by Sunday, you could still be seeing the effects. And that means that some patients, might like that because that improves the spontaneity of sexual intercourse, which, I've often struggled with is, deciding an hour before the time you're going to pop a tablet and you still have to keep the mood going. Avanafil is the fastest onset at 30 minutes, and that's so appealing because it improves the predictability. So in the same way that a long-acting agent can improve it, if you've got one that can work rapidly, you can also improve the predictability. A few key concepts with them, however, and then it's probably worth mentioning that tadalafil once daily myalgia that we're aware of, so patients need to be counseled that you can have some pain. And then the key concept here also is that you need to titrate an agent to maximum dose before saying it's not working. And they recommend that you need to have tried it at least 9 to 11 times, which is a very interesting concept because we can get sildenafil from our pharmacy on a single, I believe you can get 250 milligram tablets for the patient to try. And, reading this, then I think to myself, so what does that do if it doesn't work? Is the patient going to move on from that and believe it doesn't work? I mean, that's far under 9 to 11 times. So I think that's an important concept when you're starting patients on this treatment. Absolute contraindication is nitrate use in any form. And we know that if you develop chest pain during sexual intercourse, they shouldn't receive nitroglycerins for 24 hours for all of the agents, but specifically tadalafil, 48 hours they recommend. Right, so second line and surgical options. So intracavernosal injection, alprostadil, prostaglandin E1, 70% efficacy as a monotherapy. That jumps up to 90% if you add phentolamine, a non-specific alpha blocker, or papaverin, that's a non-specific phosphodiesterase inhibitor. Key things there is you obviously need to train the patient. The struggle for me with this one is, patients use their last bit of money to go and get this, which can be formulated in different amounts. And, you don't want to overshoot by being too strong, but you don't want to undershoot by being, too weak. And I'm not sure that everyone can afford to go and get a second one. So I think that remains a challenge for people who can just afford it is, getting that dose right, and titrating it. And then side effects is pain at the site, priapism. We have a nice sheet downstairs that we give the patients and we explain that if your erection is persisting as you approach 3 hours, they need to come back. They need to say that they've been injected with this, and then we'll give them some phenol. Your vacuum devices, so first your intraurethral therapy, you can get alprostadil, which is given as a pellet in the urethra. The response rate is only about 50% for that. Worth mentioning, just back on intracavernosal injections, it's a great option then for post-radical prostatectomy, because the idea there is that you've got some autonomic nerves that's disrupted. So local therapy with the ICI is preferred in that setting. And then there's an agent, Eroxon, that's the first over-the-counter approved topical gel. I'm not sure if that's in South Africa, but you can apply it onto the glans and within 10 minutes it will have onset. Vacuum erection devices, it's quite a wild thing if you see it happen. I think Dr. Masi was the first one to show me that device. Seemed like quite an expert with it. But they say that you're going to have a response of about 90%. But it's a very niche group of patients that need this because you're essentially sucking blood into the penis and then holding it there with a ring. So they really say that it's for older gentlemen who are in stable relationships, and it's, you can understand that for them, it's about pleasing your partner, and, they just want to be able to have the intercourse per se. Maximum of 30 minutes, you're allowed to have that ring on. And then penile prosthesis, it's a definitive treatment. Both the malleable and 3-piece inflatable devices are available. Partner satisfaction and patient satisfaction is 90%. The statements in in the guidelines that probably the highest satisfaction rate for a procedure. And then revascularization, that's a unique patient, a patient under 55, they're not a smoker, they don't have diabetes, and you've proven traumatic etiology with angiography, they can benefit from revascularization. So, at the end of a lot of these chapters, there's always the sort of the investigational stuff. And I think the key point here is that conceptually, a lot of these things make sense, but what they translate to on humans often falls short. So with that said, we can have a look at these investigational therapies, but they are recommended as investigational therapies. They're unproven. If people are going to pay for this, you've got to tell them you're paying for something that doesn't necessarily have a good evidence. So the one article that had some sort of interesting data is that the combination of electrical stimulation of the penis as well as exercise can produce a improvement in your erectile function score of about 6.81. So they say like that's quite a significant jump, especially more significant than low intensity extracorporeal shockwave therapy. I mean, that's always a favorite to be asked because, the idea that this can improve vascular neogenesis is great, but the data on it is pretty, dismal. A plus 0.65 on this on your score is pretty. I don't think it's really good or showing much. And then you've got stem cells and platelet-enriched plasma. So stem cells make sense. You want to replace damaged tissue, and then platelet-rich plasma is that you want to provide growth factors. But once again, both of them have very limited data on actual good outcomes in humans. Botox as an intracavernosal injection is an interesting one. The mechanism basically there is that if you can block noradrenaline release, then what's left at the neuromuscular gap there is that you're left then with nitric oxide. And so by virtue of there being tons of nitric oxide, you can improve the erection. There's some data that says that this could show some benefit, but it's very short term. So that's why it remains under investigational. So as we sort of wrap it up, there's sort of key recommendations that I just want to touch on. And I think that this adds value to practice. And the first one is that, as we said, shared decision making. People need to understand what's on the table and why it's on the table for them, which means that we need to understand stuff about the drugs, about the injections, and about the surgery. Before you can declare someone has failed PDE5 inhibitors, you've got to make sure that you've titrated them to max dose and they've had a maximum number of attempts, so 9 to 12. Testosterone deficient men, 3 months. You want to get them to 3 months of being Hugo nadal. And then you could also give phosphodiesterase 5 to augment that. And finally, cardiac referral. We need to risk stratify these patients and then refer them because it could be their first presentation of cardiovascular disease. So it is common, it's multifactorial, it's a cardiovascular sentinel marker. Don't miss the opportunity to screen these guys for cardiovascular disease. Tell patients and have their partner with about what are the options. Still recommended you can start with a phosphodiesterase 5 inhibitor. The historical recommendation was stepwise, but people can choose to jump that, perhaps go straight to intracavernosal injections, and then emerging therapies remain investigational. So my references. Thank you.
Thank you, Dr. Rhode, for an excellent talk. Do you have any questions on the floor? Any questions in the chat that we can see there? We've got a question here from Prof. Laz.
Thanks, Eli. Exceptionally well put together talk. Intracavernosal injections are obviously second line. Do you know what's in trimix and how those constituents work? What's the difference between trimix and the quadmix?
Yeah. Sure. The question from the floor from Prof. Lazarus was, do we know what's in trimix and how does trimix and quadmix work? Trimix has got alprostadil, which is synthetic prostaglandin E1. It's got phentolamine, which is a non-specific alpha blocker. And then, as mentioned, it's got papaverine, which is a non-specific phosphodiesterase inhibitor. So you get sort of this pan blockage of the degradation of both that cyclic GMP and cyclic ATP. Quadrimix, it's going to escape me what that fourth agent is that they put in. I don't remember. Oxytocin. Doesn't sound right. Atropine. Okay. Right. Atropine. Maybe.
Okay. Thanks, Akila. Any other questions on the floor before we move on? Okay, good. So our next talk is Dr. Hugo, who will be taking us through premature ejaculation, investigation and management thereof. Come on.
Just to be back. Yeah. Wait, so I just go here. Share. Let's say content only as background. Assume that, right? No, just share. See. Let me try to get the yeah, almost giving away my chugs. Shouldn't do this. Sorry. I've seen this. Displays. Okay. Good. Yeah. Okay. There we go. Should work now. Oh, that's just that. It's doing that. Okay. It's like it's not that one. And that's the one that you see. Oh. Sorry. Keeps extending, sorry. Okay, just do this. Okay. That's the Good morning, everybody. What a tough act to follow. Thank goodness I don't have to consummate my marriage at the moment because I'm so nervous. I will fall into both categories of these talks. Yeah, like Aman said, my name is Carl-Adriaan Hugo. I'm a baby urologist, medical officer. So today I will not be speaking out of any anecdotal experience or any anecdotal evidence, fortunately, but more from what I've read. But I also haven't really seen a lot of patients with premature ejaculation. And just as Eli was talking, I was reflecting, and I feel that this is the complaint where we say, we're not going to worry about it now. Let's talk about your other complaint. Let's not waste time on premature ejaculation while we have other patients with penile cancers and everything waiting. But I'll try and be quick and over before you know it, in keeping with the topic. Growing up, I watched a TV show called Friends, and there's this scene in Friends where there's this little bit of incident, and they're alluding to something happening from the male partner in the scene, and it completely went over my head as a teenager. And especially when it came to this one, and this gets quoted quite often. It's not a big deal. It's not that common. It doesn't happen to every guy. And I just want to tell Miss Rachel Green that it is actually very common. Latest data suggests that up to 30% of sexually active men will experience a form of premature ejaculation some point in their life. 5% of these men, it's a true intravaginal ejaculation latency time confirmed premature ejaculation, and it is in fact, according to the EAU and according to the International Sexual Society Sexual Health Society, Medicine Society, it is the #1 most common male sexual disorder.
So, reading up on it, there's a couple of confusing definitions, also difficult to interpret. The first truly defined academic definition of premature ejaculation came from these two people. If you don't recognize them, this is Masters and Johnson, also the so-called Masters of Sex, who identified defined premature ejaculation as the inability of the male to control ejaculation sufficiently to satisfy his female partner in more than 50% of coital episodes, provided that she is not anorgasmic. You can agree with me that is quite a difficult definition to interpret because it's very subjective. Strasberg et al. Also defined this condition, once again, very subjective. Even the World Health Organization has a very subjective definition of premature ejaculation. Thank goodness, the International Society of Sexual Medicine came up with a very exact, clear definition just to remove some of the subjectivity, as well as the DSM-5, where they said, where when you go to the ISSM definition, it's defined as ejaculation within 1 minute of vaginal penetration. That is in lifelong premature ejaculation. We'll get to the classification a little bit later. But it's also defined as a reduction in latency time, often to about 3 minutes or less, in acquired premature ejaculation. We'll get to the definition a little bit later. Important caveats on these definitions: there must be an inability, whether it's subjective or objective, to delay ejaculation on all or nearly all vaginal penetrations. And as with all DSM-5 classifications, there must be a negative personal consequence that can include stress, bother frustration, or sometimes avoidance of sexual intimacy. Just interesting note that the ICD-11 actually changed the definition and the name of premature ejaculation to early ejaculation. But the EAU still calls it premature ejaculation. So for the purpose of this talk, we will still refer to it as premature ejaculation. Once again, it is very difficult to define this topic because a lot of this is subjective. And in the classification, we'll discuss later about the variable and subjective premature ejaculation as well. So we can't talk about pathophysiology without talking about physiology. So Dr. Rhode fortunately already discussed the physiology of an erection. I'm not going to go into detail of the physiology of sexual stimulation, but I just want to talk about the physiology of ejaculation. And ejaculation is controlled by the spinal ejaculatory generating center. I've read the origin is in different places. Some sources say it's at level 1 to 2. I also read sources where say it's at level 1 to 2, level L1 to L2 in rats, and similar in humans. Other sources say it's at L3 to 5. But this center actually basically receives parasympathetic and sympathetic inputs from the penile nerves and communicates via sensory and motor nerves as a reflex to have the ejaculation as a result. In addition to the spinal ejaculatory center, the central spinal and peripheral nervous systems also work together for emission and ejaculation. So this ECG integrates the signals. And important, the other pathway is either pro-ejaculatory or inhibitory signals from the hypothalamus via your dopaminergic or your serotonergic pathways. That brings me to serotonin. You cannot talk about ejaculation without talking about serotonin, because serotonin has a direct role in ejaculation, either inhibiting ejaculation with your serotonin 2C and all the serotonin 1B subtypes, or activating and facilitating ejaculation via 1A subtype. Next, we talk about the two phases of ejaculation. Your First phase is the emission phase, basically where the seminal fluid goes from the prostate and the seminal vesicles to the posterior urethra. The internal sphincter close to prevent retrograde ejaculation or retrograde flow. And this is controlled by a sympathetic, or your sympathetic autonomic nervous system. Once again, the sources of the spinal nerves involved differs, but this is mainly driven by the pelvic plexus and your inferior hypogastric plexus, your hypogastric nerves, your caudal and paravertebral sympathetic chains. So, takeaway point here, this is the first flow. This can sort of still be stopped when we talk about management a little bit later. But once semen reaches the posterior urethra, ejaculation becomes inevitable. And like I said, there is an element of cerebral control in this area. Then we talk about the second phase, which is the expulsion phase. This is where the seminal fluid is expelled from the posterior urethra through the external meatus. This is controlled by your spinal cord reflex S2 to S4 by the pudendal nerve that causes rhythmic contractions of the bulbous spongiosum and the ischocavernosus muscles, and contractions happen at 0.8-second intervals. This is accompanied by orgasm. I'll talk about that quickly now. And this is mediated by your somatic nervous system. As part of the second phase of ejaculation, it's accompanied sometimes by orgasm, but we must just always remember our patients are sometimes like the other guy on this picture, where they sometimes get the two confused. You don't need to have ejaculation to have an orgasm. An orgasm is mainly central response, central process. As we all know that orgasm can occur without any genital sensory input or ejaculation. When it comes to pathophysiology of premature ejaculation, a couple of theories, and a couple of factors that can play a role. Like I mentioned before, serotonin is directly involved, where your serotonin 2C receptors can be hypersensitive, or 1A receptors can be hypersensitive, and this reduces your ejaculatory threshold. And central serotonergic deficit is the dominant theory for lifelong premature ejaculation. Once again, we'll get to the classification a little bit later. Second thing that can be a cause for premature ejaculation is glans hypersensitivity, where there's an increased density of somatosensory receptors in the glans penis, which has a lower sensory threshold, and you reach an earlier point of no return. Other factors that can play a role is your genetic polymorphisms, where that serotonin transporter gene sometimes is linked to a shorter intravaginal ejaculation latency time. There's a strong familial hereditability, once again, of lifelong premature ejaculation. As with erectile dysfunction, hormonal components or hormonal factors play a big role, especially hypothyroidism, hypogonadism, and oxytocin. That's all implicated in acquired premature ejaculation, and an endocrine screen and endocrine panel should be included in your workup of new cases. Dopamine and oxytocin, and when we get to treatment therapies, oxytocin is an exciting new therapy field that's being explored. But dopamine is pro-ejaculatory response, and oxytocin is anti-ejaculatory, where there's a role of influence and impact on your GABA and your nitrous oxide pathways. I'm not going to go into that too much detail. And important massive psychogenic factors also play a role. Like I mentioned before, it's always subjective and patients think it's worse than it is. My AI assistant actually at this point gave me a caveat that said, don't tell your patients it's not as bad as they think it is, because for them it is. When it comes to diagnosis of this is of premature ejaculation is mainly based on history, because you can imagine it is quite difficult to examine this in a patient. So the EAU strongly recommend the history as part of your diagnosis and workup, and talk about your self-estimated intravaginal ejaculation latency time. Just a small comment on that. The EAU also mentions that it's actually quite difficult to talk about the intravaginal ejaculation latency time because men often experience premature ejaculation without vaginal sexual activities, such as masturbation, oral sex, or anal intercourse. So I just get a feeling that they're going to change this definition at some point soon, but for now, it's the intravaginal latency time is still the phrase that's preferred. Included in your history, we also should inquire about perceived ejaculatory control, personal distress, interpersonal difficulty, partner impact. How long has it been? So important to differentiate. Is it lifelong or acquired? Lifelong is from the first time you had a sexual encounter. Did you ejaculate very early, or did you have a period of normal, so-called normal latency time, and did it change? And that's quite important to determine because it changes our treatment management. It should inquire about coexisting erectile dysfunction, UTI, prostatitis, and we should include a proper endocrine symptom screen as well. We have validated questionnaires. The first two are validated by and recommended by the EAU, where the first one was a premature ejaculation diagnostic tool. The second one is an Arabic index ejaculation tool. Apologies, I still meant to read up and go through them, and then I actually did not. So I actually don't know what they entail. Other things like your premature ejaculation profile and your index of premature ejaculation are not recommended by the EAU yet, but they mention that we can sometimes measure control and satisfaction or symptom severity there. And interesting, like I said, we are heading towards a little bit of a change in definitions. The masturbatory premature ejaculation diagnostic tool questionnaire is being validated by the EAU as we speak, as per the 2026 guidelines. I'm skipping over it just for the sake of time, but as Dr. Rhode also mentioned, your physical examination is important. I'm not saying you should only take a history in these patients. We must examine for concomitant erectile dysfunction, genitourinary infections, prostatitis, but there's no routine laboratory investigations that we can do to determine whether you have premature ejaculation. Just comment on the stopwatch latency time measurement. At the moment, the EAU says, don't tell your patients to go and use a stopwatch. I think that contributes to performance anxiety and stress. So for now, that's clinical trials only. I don't know, and I don't want to be in the room when they do those clinical trials. When it comes to classification, like I mentioned before, your lifelong premature ejaculation, your latency time is less than 1 minute from your first sexual experience, and the cause is neurobiological. This is where your serotonin hyperfunction and genetic plays a role. There's a 2.5 to 3% prevalence, and the dominant theory is the serotonin dysfunction. Acquired secondary premature ejaculation is a latency time which is changed from your baseline. So you need to have a period where the patient says, I did have it before, and this is usually biological. Other things like erectile dysfunction, prostatitis, hypothyroidism. It can also be psychological, with performance anxiety and all those things play a role. And the EAU recommends that we treat the underlying cause first. Your natural variable premature ejaculation and your subjective premature ejaculation, always difficult because, like Dumbledore said, just because it happens in your mind does not mean it's not real. It's real symptoms for the patients, but it's just difficult to determine. So the history is important. If your latency time is inconsistent, sporadic, it's often a normal biological variation, normal day-to-day life, and we reassure our patients. And when you have subjective premature ejaculation, where with a so-called normal latency time, there's a subjective perception of too fast, and this is sometimes just the cause of unrealistic expectations or relationship issues. And here, psychosexual therapy does play a role, and we should not medicate a normal latency time. When it comes to medication, a couple of options. It was quite interesting for me to read up on this. Duloxetine is the first line treatment drug of choice according to the European guidelines. It comes in dose of 30 to 60 milligram tablets. It is a short-acting SSRI, and it is a on-demand SSRI. As with some of the on-demand treatment that Dr. Rhode was alluding to, this gives some spontaneity. It just helps patients. There are some side effects, and patients can report up to 4 times increase in your latency time. Another first-line treatment. This is a long time. I think it was developed. I might be corrected, but it's been in use since the 70s. It's a lidocaine or a prilocaine spray where you topical anesthetic, you numb the penis, and you decrease the sensitivity of the glans. And you can actually, some patients report a 6-fold increase in your latency time over the course of 3 months. Just side effect cause a caution there that you can have genital hyperesthesia, and it can be transferred to the partner. So condom use is recommended. Interesting off-label use of SSRIs. I'm just talking about paroxetine and sertraline here, but citalopram and fluoxetine can also be used. This is off-label use. Caveat here is that unfortunately, you should have a daily use. It's not an on-demand dose that you can use. And these patients, it's a long-term use. And unfortunately, ironically, long-term use of this can decrease your libido and affect erectile function. Clomipramine is a tricyclic antidepressant that is recommended for use with efficacy comparable to SSRIs. What's nice about this one compared to the other SSRIs, that you can use it as a PRN dose as well, a couple of hours before anticipated sexual intercourse. Now, interesting enough, I did not know this. The EAU has a big paragraph on tramadol. Off-label use as a third-line medication. It can be used as a PRN dose, and the idea is that the opioid receptor agonism. How can I mute? Sorry, we just have. I'm still done with Zoom. Thank you. Sorry about that. So off-label third-line use, where the idea is that the side effect of serotonin or noradrenaline reuptake inhibition plays a role in your ejaculation reflex then. But the efficacy is reported as moderate latency time improvement. And we all know the side effect profile. People actually generally feel bad when they're taking tramadol. I can't think that they'll be in the mood when they're taking tramadol. And an adjunct to these therapies, not a direct first-line therapy, is your PD5 inhibitors on standard doses, where the idea is that it changes your perception of your ejaculatory control, actually does not do anything specifically to the ejaculation reflex. There's a limited latency time effect, but there's a reported increased benefit when taken with SSRIs. Just a comment, I did not know this. I did not think we had something in South Africa, but boxetine is apparently available. Personally, have not prescribed or used it. The SAPRA approved form of duboxetine in South Africa is called Trilogy. Yeah, and it's available in 30 and a 60 milligram dose. And it's not recommended for people younger than 18 years or older than 65 years. Why am I not moving along? There we go. Because there's a massive psychological component as well. Cannot talk about this without talking about the behavioral and psychosexual therapies. Appropriately named Dr. Siemens in 1955 described the stop-start technique, where the partner stimulates the penis until pre-ejaculatory urgency arises, advised to stop, wait, and repeat. And this reportedly trains ejaculation control, and some of the sources I read said up to a 65% increase in latency time and a short-term success. Long-term success of this is still uncertain. Once again, the masters of sex, Masters and Johnson, described the squeeze technique. The way they described it, I think it's difficult to interpret, because the way they describe the hand placement and everything is different. But some of the variations online say, at your point of no return, put your thumb and fingers below the glans or at the base, regardless of you or your partner. Squeeze for several seconds until you have the diminished urgency via your bulbous spongiorsis reflex, or the so-called internal squeeze via pelvic floor contractions can also work. Pelvic floor therapy, Kegel exercises. The idea is that you strengthen your bulbous spongiorsis and ischiocavernosus reflex. There's a significant increase in latency time reported with these patients with pelvic floor dysfunction. It's safe. There's no adverse events. And it's a first-line treatment for patients with premature ejaculation from pelvic floor dysfunction. But different studies show a different improvement. Psychosexual or cognitive behavioral therapy is more aimed towards addressing anxiety, performance fears, unrealistic expectations, relationship dynamics, and based on 3 pillars, where you empower your patient, you create a safe environment, and you have realistic expectations. And this should obviously involve the partner. Sensate focus therapy, also an interesting, once again, the idea of a desensitizing therapy, where I think it's just a fancy term for safe foreplay. The idea is that you progress intimate touching without intercourse, so longer periods. They also recommend, Masters and Johnson also recommend that you do it. And this is the place where you put a massage, dim lit room, candles. And the idea is that you remove the performance pressure, and it's used with some of the described behavioral techniques. And as with erectile dysfunction that Dr. Rhode also mentioned, combination of these with SSRIs and your psychosexual counseling have your highest success rates. Important to note that we must include sexual partners in these discussions as well, because sometimes the changing of perceptions and techniques can have a significant improvement in our patients' latency times. There's some interesting novel therapies emerging. You get neuromuscular electrical stimulation, where it's electrostimulation of the pelvic floor muscles. It changes your contractile strength, and early data seems promising, because patients will agree that it is a drug-free option. Low-intensity shockwave therapy was initially primarily established for erectile dysfunction. Dr. Rhode mentioned it. At the moment, crossover benefits are explored. Yeah. Hyaluronic acid penile injections, designed and advertised by our Asian colleagues. We have glance augmentation with hyaluronic acid penile injection to reduce sensitivity, but the EAU actually recommends it's a weak recommendation. Funny enough, a lot of clinics that I see with intimate aesthetics, they describe this. There's a big practice in Natal doing this. The EAU is recommending to use with caution and rather use some of the more established modalities. Another described, I think it was the Japanese, where they described a dorsal neurectomy, where you physically cut out some of the nerves and surgically reduce your gland sensitivity. And the EAU recommends not to do this at all. Some of your herbal supplements, acupuncture, pelvic floor physiotherapy, there's limited review for that at the moment. Sometimes you have subjective positive intra-group outcomes, but the studies and the review articles actually have high heterogeneity and biases. And I don't know if it's a good or bad thing that I did not read up on the vibrotactile desensitization devices or music therapy, where there is a randomized control trial with music therapy. The data is encouraging from that randomized control trial. It's appealing for drug-free spontaneity, but the data at the moment is preliminary. Just some special considerations, like Dr. Rhode mentioned, it can happen concurrently with erectile dysfunction. And the idea is that you treat your erectile dysfunction first, and then your premature ejaculation often resolves. Only once, if premature ejaculation persists after erectile dysfunction treatment, do you treat the premature ejaculation specifically. With prostatitis and a UTI, in acquired premature ejaculation, we obviously treat that first. Once again, just to comment that midstream urine analysis, PSA, antibiotic. So that is should be part of your physical examination. Common in thyroid disease as well. And we need to do thyroid function tests in new onset acquired premature ejaculation. Like I mentioned before, in adults and young men, we prefer behavioral psychotherapy, sexual therapy. Duloxetine is not approved for gentlemen younger than 18 years. Partner should always be included in these discussions, and sometimes it's subjective. I think Masters and Johnson alluded to the fact that female satisfaction should also be involved, and sometimes the perception from the man differs once you involve your female partner. And interesting enough, the FDA hasn't approved any of these therapies in the US yet, and I actually did not read up on why. Thank goodness we have it in South Africa, duloxetine. This is a summary of the recommendations from the EAU. Like I said, Ms. Rachel Green, it is that common. It doesn't happen to every guy, but it is a big deal. Lifelong premature ejaculation is mainly driven by serotonergic hyperfunction, and we give pharmacotherapy as a first line. Acquired premature ejaculation, we need to treat the cause. Duloxetine and lidocaine spray are first line treatments. combination therapy involving partners does give us the best outcome. Thank you. Any questions?
Thank you, Dr. Hugo, for that excellent talk as well. Do you have any questions from the floor in the chat? Let's have a look. We have a question, Dr. Matiba.
Specifically, the urosynaptic upper blockers for the management of these patients to make them not premature ejaculation.
The question is if there's any role for alpha blockers in treatment of premature ejaculation, specifically the urogenital specific alpha blockers. At the moment, I've seen it's like with oxytocin therapy, and there is novel therapies being developed and early promising results in some trials, but I think the evidence is still lacking to make it a full recommendation at the moment. Also read up that you do have some symptom relief once you've treated sort of like the underlying cause, like sometimes BPH, all those other things has a role and as an effect, and the alpha blockers sometimes come in there. But because serotonergic hypofunction or serotonin dysfunction is the main theory behind lifelong premature ejaculation, SSRIs is the treatment of choice for primary premature ejaculation. That's how I understood it, my reading.
Thank you for that, Dr. Hugo. We have another question on the floor from Dr. Mandla.
Maybe not a question, Ahmad, but maybe a comment, but maybe then it involves Dr. Rhode to further explain something to me. You forced me to go back memory lane, Eli, in that in those 3 years of medical officer, we're exposed to running the erectile clinic, which is by far was one of my most favorite times in urology. You get the most satisfied patients if your outcomes come right. And I just wanted to add sort of to the register, Chris, how we did it or how we ran it is you got the guys to come in, you train them on the vacuum pumps, you train them on the ICIs, they always get the first dose for you. And what we came up with at the time, which worked well actually, is that they bring partner. If they are outside your 30-kilometer zone from the hospital, they get a place close by. I had a concept that says you'll never waste any erection. And then they'll go with their partners. You give them your cell phone number, and that is critical. The reason I say that is critical, we tend to see a lot of priapism that come via the men's clinic. And I say this with from a good place in my heart that they try to assist the men's clinic, but after 4 p.m. it's closed. Guy shows up at C15 with a priapism that has lasted more than 4 hours. And unfortunately, we do know then that leads to further consequential pathophysiology. So I always will give them our numbers. I'll give them my number, and it will be the most gratifying call you'll ever get. Doctor, it went well. Your magic worked. But having said that, Eli, I'm also forced to think that if we're to do a quick survey across the country with registrars, we'll find a lot of psychological cause for ED, and that might be a reflection of the stress levels that come with training. The reason that I bring that up is I asked this question with two quite specialists I respect. Bhavik Shah is one of them, to say, is there a role for PDE5s in the setting of psychogenic erectile dysfunction in order to prevent, as a prophylaxis drug? Nitric oxide is known to improve the vascular endothelial lining. And funny enough, in the recent SAUREM I attended, Ackerman, who I respect very much, made a joke to say the only drugs he's looking forward to be on is simvastatin and the PDE5, in that he believes it's very cardioprotective and also in the setting of ED. What would your comment be to that? Your reading tends to go quite in depth. Is there a role of the prophylaxis?
Yeah, look, it's always difficult to comment on something that doesn't affect you. So, I'm not sure what the data on that is. And I think that, it seems that you've got a one-man cohort already, and perhaps you're on your way to establishing a good retrospective review. That's sort of my comment.
Thank you for that, Dr. Mana and Dr. Rhode. Any other questions on the floor in the chat? I don't see anything popping up here. Just want to thank everyone for joining us this week for the webinar. So I want to remind everyone, if you saw the advert for the SAUA conference in October in Cape Town this year, please visit the website. Early bird registration is opened up and it's closing in July. And also feel free to submit your abstracts as well. Thank you for joining us, and we'll see you next week for the next webinar.